Hello, my name is Keith Flaherty. I'm a medical oncologist from the Massachusetts General Hospital Cancer Center in Boston, Massachusetts. And at this year's ASCo 2016, I have the pleasure of presenting a genomic analysis and 3-year efficacy update of the so-called COMBI-d trial. We've previously presented and published the initial analysis for this phase 3 trial, which was conducted in BRAF mutant metastatic melanoma patients. It had already been established that Dabrafenib monotherapy, a selective BRAF inhibitor, has efficacy compared to historically standard chemotherapy. And in this phase 3 trial, the combination of Dabrafenib with a MEK inhibitor, Trametinib, was being evaluated in comparison to Dabrafenib monotherapy. You can see that this study enrolled ultimately 423 patients and equally randomized them to find the BRAF mutant population, which is about 45% of all metastatic melanomas. Just under 1,000 patients had to be screened initially. You see here the key eligibility criteria as well as the stratification factors on the left. So the patients were balanced based on a couple of known prognostic factors, including serum LDH level, which we know is both prognostic and to some degree predictive of outcome in the setting of many systemic therapies. You also see on this slide the primary analysis for progression-free survival and overall survival that were previously conducted. The purpose of this year's ASCo presentation is a 3-year update, looking at both progression-free and overall survival. So those outcome data are shown here for the overall population. You see progression-free survival with 3-year minimum follow-up now in this cohort of about 22% in the patients receiving Dabrafenib, Trametinib combination therapy. Notably, there's a subpopulation of patients on the BRAF inhibitor monotherapy arm, 12%, who are still progression-free even out to 3 years' time. An interesting observation when you consider how long-lasting this disease control or response can be to either single-agent or combination targeted therapy in this disease. The overall survival outcome, not surprisingly, superior, with 44% of patients on the combination regimen alive at the 3-year mark, and favorable compared to the BRAF inhibitor monotherapy arm. That's notable because in this trial, patients who had disease progression on BRAF inhibitor monotherapy could in fact cross over to the combination regimen, and yet you still see this persistence in overall survival improvement. So this 44% landmark is really the highlight result of this updated analysis and is a better 3-year overall survival rate than we've seen compared to any systemic therapy ever evaluated in this disease. A notable point to pull away from this analysis is that of those patients at the 3-year mark who were still alive on the D+T arm, 58% of them were still taking their assigned protocol therapy of Dabrafenib and Trametinib. We sought to understand whether there might be clinical features that allow us to enumerate patients who have a particularly good clinical outcome. And we've in fact presented some of this data in previous congresses within the past year, but at that point with only 2-year follow-up data. So now looking with 3-year follow-up data and using just clinical features, serum LDH and number of metastatic disease sites, we're able to pull out a subpopulation of patients who do even better than the overall population, and significantly so. You see here the fraction of patients with normal LDH and few disease sites at baseline who are progression-free and overall survival data as well, alive at the 3-year mark. So 62% of patients alive at 3 years in this subgroup. And this basically was the best we could do in terms of selecting out an excellent prognosis group for this type of therapy. Again, this type of data is the high watermark for 3-year outcomes that we've seen with any systemic therapy in this disease. Now, the next layer, which we're presenting now for the first time at this Congress, is a deep genomic analysis of a subset of the patients who were enrolled in this phase 3 clinical trial. We were able to obtain tumor material from prior to study enrollment for a large number of patients on either the Dabrafenib Trametinib arm or the Dabrafenib monotherapy arm. These patients, in fact, were selected based on their response or non-response. So in other words, we were looking for populations from either end of the clinical outcome in this analysis. We performed whole exome sequencing, so we looked at many, many genes, thousands of genes, and out of that, we were able to identify recurrent alterations, particularly in the common tumor suppressor genes shown here. So TP53, CDKN2A, and PTEN are all tumor suppressor genes that are known to co-occur with BRAF mutation and known to confer somewhat of a worse prognosis as well as resistance in preclinical studies. So we were interested in whether or not these genes might confer a difference in outcome. Sure enough, CDKN2A loss, either by mutation or deletion, conferred worse outcome. Patients who had these alterations had significantly worse both progression-free and overall survival, as you can see here. Beyond that, the only other genomic factors that had statistical significance even after a multivariate analysis that included not only genomic characteristics but also serum LDH, you see that mutation burden or mutation rate was actually a significant predictor. Notably, it was only for overall survival, not progression-free survival. And that tells us that this is probably a prognostic marker more so than predictive. Nonetheless, you'll note that this subset of patients who had normal serum LDH and a high mutation rate had an 80% 3-year survival rate. So this genetic evidence supports the notion that once we go beyond clinical features into genomic features, we might be able to in fact identify a subpopulation of patients who have a particularly excellent clinical outcome. So in summary, we have 3-year follow-up data that shows a 44% survival rate with this regimen of Dabrafenib and Trametinib, clinical features that allow us to identify a population who does even better with a 60+% outcome, survival outcome, and then looking at the genomic features, we're starting to get hints of strategies that can identify patients who have an even better outcome at the 3-year mark. And this is going to motivate additional studies with more time, accruing more patients and longer follow-up even for these patients to help us try to discriminate these patients who do exceedingly well. Thank you so much.